Hi, everyone. I'm Alescia Azzola, and I just wanted to thank the association, thank Deanna for inviting me. I'm very excited to speak to you today. Genetics, we'll be talking about genetics and pituitary. Genetics is in its infancy, right? So I'll explain some of the major concepts and why I'm so excited about it, and I welcome some questions, and we'll take it from there. So these are my disclosures and my honorarias. There's really nothing that has to do with today's talk. We'll be discussing the concept of genetics in medicine, the indication for genetic testing, the benefits, and how we can potentially use it as a therapeutic tool to guide our treatments. And we'll look at two real cases where patients that actually did change their management and the management of their families. Why is genetics important? Well, we've been saying this. The two speakers ahead of me as well have mentioned it as well, that there's a delayed diagnosis in acromegaly. Mean is 5.5 years, but can be 5 to 10 years. Over 24% of the population with acromegaly are diagnosed after 10 years of having symptoms. And they usually present with a mean of 4 comorbidities, right? The more we prolong the delay in the diagnosis, we increase morbidity and mortality. And we have to find different ways to pick people up early, right? It'd be interesting to pick it up even maybe day 1 or day 2. Stay tuned, we'll see. This is the picture that I love to show about acromegaly. It's showing the percentage of patients that have seen other specialists before they're finally diagnosed, right? So they'll see the internist, the dentist, the cardiologist, the dermatologist, the neurosurgeon, the psychiatrist, the gynecologist, the ophthalmologist before they finally get their diagnosis, right? So what can we do? Reasons for genetic testing. We discover if there is some familial inheritary disease. So is it genetic? Will it pass down to the next generations? So earlier detection of the diseases and earlier treatment. And most importantly as well, we can screen the family members after, so we can pick them up as well early. And if we can pick up a small little tumor and monitor it through time, small tumors respond better to therapy than the big tumors with major complications. We may be able to pick out these patients that are genetically prone to acromegaly before they even have one complication. And we have an overall better medical outcome. So, the frustrating part is some individuals will come to my clinic, will do genetic testing. I tell them they do have a genetic mutation, but we don't need to screen their family members. They almost get angry. They're like, what are you talking about? You just said it was genetic. What do you mean I'm not screening my family? This is where genetics is complex. 2 big categories of genetic mutations. You have germline, which is hereditary. It can be isolated, where you just have a genetic problem for acromegaly, or syndromes, where there's multiple different conditions because of one DNA mutation. Or somatic, which is not inherited. You don't pass it on to the next generation. How can we understand this? Well, Grandma's special muffin recipe. Okay, we're going to talk about muffins now. So when we look at germline mutations, we're looking at a DNA problem before the baby is formed, the fetus is formed. So it's a mutation either in the egg, in the ovary of the mother, or the sperm. Okay, so my analogy, I'm thinking about it, I'm like, okay, well, Grandma's recipe, before it was a recipe, there was a paper, so that could be the egg, and there was a pencil or a pen, that could be the sperm. Well, what happens if you go to copy Grandma's recipe and you want to make these special muffins, and there's a hole in it, right? So there's a mutation in the paper, a mutation in the ovary, in the egg. Well, then you're going to say, well, I need half a cup of... I have no idea. And I need to mix the eggs into, I don't know, right? What about the pen? What about the sperm? If there's a mutation in the sperm and all of a sudden the ink runs out, it says, well, I need to add sugar and beer? I don't know. We don't know, right? Or if it wrote something different? Instead of setting the oven at 360, it's 900. We're going to have a problem. 900 degrees with muffins, we're going to burn them all, right? So it is a mutation. It could be in the egg on the paper, or it could be on the sperm, or it could be both. And the very important thing to remember, that means that when you pass down the recipe to the next generations, that recipe always has holes in it, always has a mutation in it. So it's going to pass to the next generations. All the muffins will have something wrong with them. Okay, so that's germline mutations. And we'll be able to tell on the DNA, yep, we need to screen the rest of your family. Then we have somatic mutations. This has nothing to do with Grandma's recipe. She took care of it. She put it in her little box. She handwritten it, and it is perfect. It has to do with the granddaughter that wanted that recipe, right? It's a secret recipe. So she goes, hurry up, let's go grab the recipe. So it has nothing to do with the egg or the sperm. It has to do when the cells are dividing and dividing and dividing, something happened. So let's say the niece steals the recipe, the daughter steals Grandma's recipe, but the granddaughter stole it as well. And as she's making the recipe, the paper's fine, the pen's fine, everything looks beautiful, but as she's making the recipe, she grabs the salt instead of the sugar. Well, that one batch of muffins, they're going to be pretty gross, right? They're not going to taste good at all. But the niece is going to do the recipe and it's going to be okay. The daughter is going to do the recipe, it's going to be okay. You're going to pass it down to the next generation, they're going to be okay as well. So that's a somatic mutation. It's an accident that happened while the cells were dividing. Okay, so that's first concept about genetics in acromegaly is we might actually tell you, yes, it's genetic for you, but you're not going to pass it down. Or, oh, yes, you're going to pass it down, let's screen the family. And that's very important to understand. Okay. The second part, one of my greatest mentors in genetics always says, be very careful when you do a talk on genetics because you give just enough information to make it dangerous, right? I don't want every single person here to say, oh my God, it's genetic, I need genetic testing. Maybe. Only 5% of acromegalic patients have a genetic mutation. That's still high enough for 5%, and we can do something about it. But we have algorithms, we have different predictors about the likelihood of it being genetic, and then we offer genetic testing. So that second concept that it's 5% of the population, there is a reason sometimes when we say, no, you don't need genetic testing, right? And others, absolutely, we offer genetic tests. So now there's two types of genetic problems in acromegaly. You have isolated, where the recipe, just for muffins, there's a defect in it. So every time you try to make muffins, it's not going to work, which means so in your body, the only issue with that genetic mutation will be acromegaly. And then there's syndromic. Syndromic means that, well, grandmother, not only did she not write flour in her ingredients for her muffins, she did not include it. She didn't include flour for donuts. And she didn't include flours for pies. So having this one mutation causes multiple different conditions. So now the muffins, the pies, and the donuts are ruined. So we have MEN syndrome, all these different syndromes where, yes, there's a pituitary tumor, but there's a high likelihood as well of having tumors here and having tumors here. And it helps us to know this diagnosis because then we can screen. Right? Yes, you might have a pituitary tumor, but hey, maybe we'll be able to prevent the early signs of a parathyroid problem. We'll be able to pick it up right away. So isolated, one mistake with the muffin recipe, or syndromic, there's a big problem in multiple, the same problem, same mutation is causing problems in multiple different recipes. Okay? Does that sound good so far? Is the analogy working? It's the first time I use it. Sounds good? It's going, okay, good. Okay, sounds good. My grandma actually, that is my grandma's recipe, by the way, so it's a very good muffin recipe. I highly encourage you, right? You take it down. So let's talk about the next part, is the algorithms. I'm not going to go through every single DNA, every single piece, but I wanted you guys to see that we have a lot of different mutations that we're looking at. And we have protocols, and they're in its infancy. They will get better and better as we do the DNA, as we get to know more about DNA and acromegaly. We'll be able to even discover new mutations or have even better analogs. But right now, what we have looks like this. So gigantism, right? So if you have excess growth hormone when you're young, we do different genetic testing based on the age that you develop the gigantism. Under 3 years old or over 3 years old, we have some genetic testings that we would, red flag, we should be checking. Family history, very important. And I'll show you the importance of really digging with family history. Grandma had some sort of mass in her brain. Not good enough. Let's try to see if we can figure it out. Sometimes we can't, right? But I can't tell you how many times I hear that. Oh, it was just a brain tumor, and she got it removed and it was okay. Yeah, but what does that mean? Right? So very important that we keep that alive, that family history. It's our story. And then the syndromes, there's different genetic syndromes that we check for. And then hyperplasia. If the pituitary just looks like it's getting bigger instead of one nodule in the child, there's different genetic mutations there that we can check for. So this exists, but we don't talk about it, right? Acromegaly, same thing. If acromegaly, you were diagnosed before the age of 30, we have genetic testing there. Family history, we have different genes that we're checking. And then if you have other syndromes, other symptoms. So if you came in and you did not have acromegaly, but you had a tumor in your adrenal gland, and it was releasing adrenaline, I'm still thinking about your pituitary. Even if you came for the adrenal gland, I want to make sure it's not genetic, and eventually you may have something here as well, right? And then metastatic disease, if the tumor spread, there are some genetic testing that we can do. So these are all part of our algorithms that give us a red flag that we should be doing genetic testing. We have it for the rest of the pituitary as well, right? I always describe the pituitary axis, right? I say, well, you know what? Your pituitary is 1 centimeter gland and there's 8 hormones in there. It would be like 8 family members in a bathroom. They're going to fight, right? Well, same thing here, right? You can have one that's bullying all the others and that's getting bigger and the other ones aren't working as well, right? So we have an algorithm for prolactin, so the breastfeeding hormone, when we should be considering genetic testing. We have one for when you're releasing too much ACTH, so you release too much of your stress hormone, the cortisol. We have an algorithm there. We even have an algorithm when it's just a mass not functioning, but it's growing fast. Or wait a minute, what's going on? There's metastatic disease, it's spreading. We have some genetic causes for that as well. And then very rare, but we have as well for thyroid hormone, right? So they do exist, they are out there. We're beginning to understand them. But okay, you're probably sitting there going, okay, sure, you're giving me a genetic diagnosis, but will that change my life? Will it change my family's life? Well, this is part 2 of the presentation. Let's see. This is a busy slide, but it's just showing you how, we're starting to understand that there's different treatments that we might pick, or it might be more aggressive or less aggressive depending on the genetic mutation. So I just did this like this just to kind of skim over it. But the familial isolated pituitary adenoma genetic mutation, it's autosomal dominant. You're passing it down. That recipe has a hole in it. You're passing it down through the next generation. But it happens in young individuals, mean age 24. It's very aggressive. Usually it's a big tumor that likes to spread very quickly. There's a high risk of apoplexy. We talked about that already, where it's the bleed into the pituitary. And most importantly, they don't really respond to our first-line therapy, okay? And that's important. That's where if someone's not responding at all, I might take a second look at them again and see, could they have this genetic problem? They're very resistant to our somatostatin receptor analogs. X-leg, they're very young. They're 5 years old, right? Mean age is 5 years old. And interestingly here, they don't really respond to much, but they really respond to picvisimab. So in that individual, if we know they have that genetic mutation, we may just skip right to that because we know when we put them all together, they're really not responding to anything else. So it gave us a hint on treatment. And then we have our syndromes. I could spend 5 hours talking about the syndromes, but I put them all here, and you're more than welcome to have my slides. But it's just showing, for example, the two that we see, MEN1 and MEN4, it's not men, I promise. We're not judging men here. It's multiple endocrine neoplasm. You have one genetic mutation, MEN1, that increases your risk of having pituitary tumors, parathyroid tumors. Parathyroid, there are 4 glands behind the thyroid. They're neighbors, but they hate each other, okay? Thyroid does metabolism. The parathyroid controls the calcium. You can have tumors there, and then you can have tumors in your adrenal glands. And adrenal glands, they're just a hat on top of the kidney, right? And these hats on top of the kidney, they release very important hormones. They release cortisol for stress. They release aldosterone, your blood pressure hormone. They release androgens, your male hormones. Females and males, we have androgens. And then they release adrenaline. So very important gland as well that we can't forget about. We don't want a nodule there as well. So that's the MEN. And if we have MEN plus we have one of the tumors, we are screening frequently to make sure that we pick up the early detection of the other tumors that might appear. Okay. And I'll leave that for you guys there. Those are all the different syndromes and how it can actually change management in the person. So it's very complex, genetics, but we're beginning to know about it. And I'm going to show you how it can make a big difference. Patient number 1. Patient number 1 is 65 years old. This is a real case. He has severe osteoporosis, and that's why he came to see me. Severe osteoporosis. Now, as the other presenters discussed already, there's some big red flags here. You look at his past medical history and you go, oh, la, 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 la. This is real. So, how many of these could be related to acromegaly? Well, high blood pressure, obstructive sleep apnea. He actually has some atrial fibrillation, so some conduction issues in his heart, and he's had a stent as well placed. So he's had heart disease as well. So he has coronary artery disease. He has osteoarthritis. I don't know if it's especially in the hip or not. I didn't ask, but now I have. See, we learn from each other so much. I put that in my bank there. He has high cholesterol, heartburn. His aortic and his aorta, his big blood vessel in his body is dilated. He's had stage 1 colon cancer, and he's had a pulmonary embolism. When I saw that, I'm like, am I reading a textbook? What is going on here? It was almost like, how come no one's ever checked? No one's ever checked. He's 65 and no one's ever checked. So the awareness is so important, right? He said, well, I hit a bump while I was on my bicycle and I fractured 4 vertebrae on a bike. That's severe osteoporosis. Now, the family history, I'm cheating just putting it here right now and saying acromegaly, and 3 healthy sons. Getting that family history was really hard. So he was the one that said, well, you know, my brother, I don't really talk to him that much, but he had something going on with his brain, but they said not to worry about it. And, you know, his son as well. It was a long discussion that we had that, well, you know, let's see if you can reach out to him. Let's see if you can actually get what was the problem. And sure enough, his brother and his brother's son have acromegaly. It was right in front of his face this entire time, but the family they weren't having that discussion, right? And it happens a lot in families where they are very secretive, and it might be cultural as well, where you're secretive about your medical condition. It's to develop that trust with your patient so that they try to reach out and get that family history. It is so important. So very important here, he has 3 sons, right? He has all the acromegaly features on physical exam and a list of medications now, right? Because of all the complications. You have guessed it here. Back then, we still did the IGF-1 plus the glucose tolerance challenge test, and it was both positive. And look at this. You know how I said the pituitary, sometimes they bully each other, right? Well, the growth hormone was bullying the LH and FSH that helps wake up the testicles for testosterone and sperm. So he had undetectable testosterone. Well, testosterone gets converted into estrogen, and estrogen is your bodyguard for your bones. So guess what? We just found out there why there's severe osteoporosis there. Okay? His MRI showed a 1.5 centimeter pituitary mass, and it was pushing on his optic chiasm for vision. And what's very interesting with this type of vision, right, is it's here. So you don't notice it, you don't notice it, you don't notice it, now you notice it, right? So because it's that peripheral vision, sometimes we don't even know it, especially if you're wearing glasses, right? Sometimes you don't notice it. So I actually ask patients, are you bumping into doors? Do you find you're clumsy and you're always hitting cups and you had no idea it was there? They might actually notice it more there than actually the actual vision of the periphery. So he qualified for genetic testing with that family history. And sure enough, he had a germline mutation. So what's germline again? Is it grandma's recipe or did we steal it? Come on. Grandma's recipe, exactly. Can we pass it on to the next generation? Yes, we can, absolutely. So he had an AIP mutation, and we do the genetic screening for the rest of the family. 2 out of the 3 sons test positive, and guess what? The youngest son, biochemical acromegaly with pituitary microadenoma, and actively seeking help. We just helped this little guy. We just diagnosed acromegaly. And I mean, I say acromegaly, he's young. You could maybe say even gigantism, but he doesn't have any complications. This is where I do this. Right? Like we did this, right? So very important that we consider genetics. My next slide is genetic counseling. I leave it like this so it's big, bold, and it stands out. I don't want anyone just ordering the genetic test, slapping it there and giving you your result. That's not okay. We need counseling, right? So you do need a program where we sit down, we review the risks and the benefits of genetic testing. We review, well, why are we doing this? And what are we going to do with the different results? Because sometimes we do get this likely pathologic, so likely the problem, but sometimes we say we have this inconclusive or we're not sure yet. How are you going to deal with that, right? So we do have to sit there and have a long discussion, and also a discussion about, will you be okay with revealing it to family members? I'm not allowed to. He or she is my patient, or they are my patient, not the family members. So all of that needs to be discussed before we proceed with it. And also, what are the implications of life insurance and drug plans? In Canada, it is illegal for life insurance and drug plans to ask about genetic testing. They can't. They'll ask some tricky questions and you might accidentally say it. If you said it, well, it's your fault, they're going to decline it. But if you didn't know, if no one told you, you might just say, oh, I have to disclose it. You do not have to. Okay, so counseling is very, very important. And then the second, and this is the last part of my talk, is a second patient, 52-year-old man, referred for primary hyperparathyroidism. So his parathyroid is being a bully, releasing way too much parathyroid hormone, and the calcium is going up and up and up and up in his body. His past medical history: high blood pressure, obstructive sleep apnea, and obesity. And this is where the family history is actually funny for me as an endocrinologist. I'm sitting there going, wait a minute, this is so clear. He goes, oh yeah, my brother and I, we have the same genetics. I'm like, oh, he just said the magic word, but he didn't. This is where a little bit of information can be dangerous. I'm like, okay, what are you talking about? Because my brother has the same condition as me. He has problems with his parathyroid. But we're really, really lucky because we didn't get the same genetics as my sister. My sister has this adrenal mass and that it releases some cortisol, and she had a pituitary tumor that releases some hormone as well. I'm just worried because my father has the same condition that my brother and I have. He has primary hyperparathyroidism, but he also had this tumor in his pancreas. Does that mean I have a risk of this? The answer is he has a risk of all of them. All right? So this family history was so important. I didn't need to do anything else. We have the diagnosis already. He has a genetic syndrome. It's almost, again, it's like I'm reading a textbook, and it does sometimes present this way if we really dig and we care, we take time to get to know the family history, but to get to know the patient as well, right? He has hypertension, obstructive sleep apnea, obesity as well. We should be focusing on this patient and see what else we can do for him. Skipping right to the genetic testing, because he did qualify for the genetic testing, and based on all his criteria, he was positive for one of the syndromes, MEN syndrome, multiple endocrine neoplasm. right? Where it's pituitary, parathyroid, and the adrenal gland. Now, if you remember, he had 2 daughters. Uh-oh. It was germline. Can I hear it again? Is it the recipe? It's the recipe. Can it get passed down through generations? It can get passed down through generations. So we do the genetic counseling, we get the testing, and sure enough, his oldest daughter has a genetic test. It is positive as well. So we start screening her to see, because she's fine. Both girls are like, why would we do it initially? Actually, the girl who was positive actually looked at me and she had a little bit of attitude. I liked her. She goes, why would I do this? I'm perfectly fine. I don't want to know my diseases. And sometimes that happens. And that's why the counseling is there. Sometimes they refuse to do it. That's okay. And then after she looks at me, she's like, okay, what are we going to do now? And she ended up having primary hyperparathyroidism. And this one was interesting. Her acromegaly, it wasn't a growth hormone secreting tumor. It was a GnRH. And that's something that, well, it's not very common, but it's more common in MEN1. In MEN1, you have to think about it. And what is this? Well, when you describe the pituitary axis, I always say it's grandparents, parents, and kids. I don't know why I bring it back to my family all the time. But your hypothalamus, right? The gland on top of your pituitary is the grandparents. They pick up the phone, and their phone is called GnRH, and they call the pituitary, right? So that's the hormone that's waking up the pituitary. The pituitary, the parents, they wake up and they're like, oh, my kids are going to be late for school. So their phone is the growth hormone, and they go to the liver and they wake up the liver and you release the IGF-1. Well, her problem was not the growth hormone, wasn't the IGF-1. They were both high. She had a little tumor in her pancreas that was releasing GnRH. So the grandparents, they weren't at home. They were on vacation in Florida calling the parents, right? They were in her pancreas. So because we knew she had that MEN syndrome, we look at the data and we have a little red flag that it could be that's more common in MEN syndrome, and made us think of this, and we were able to help her. So again, we're helping younger family members because we have the genetics. So it's exciting, but we have to remember, right? Only 5% of the population will have a genetic mutation, but it's about time that we start talking about it as well, and that we do the analysis on the proper individuals. And now you guys, I hope, understand why sometimes we say it's important to do the genetics and with your family, and sometimes I say, no, you don't need it for your family, you're good, you can't pass it on. So we're excited in Northern Ontario. We've been working hard on developing an adrenal and pituitary clinic, which we've launched, and we'll be making it available as well to do genetic testing, because the problem in Ontario anyways is before you would have to do a referral. It takes 2-3 years to get the genetic counseling before finally sometimes we can get our diagnoses. And I'm in Northern Ontario because I like to get angry when I see that things are not available somewhere. And I find that's the problem with genetics. We have an uneven awareness and the lack of availability of genetic testing that I saw in Northern Ontario, and you can tell me about it in your communities as well. So it's my mission to try to increase precision medicine, where we're looking at the DNA and we're helping the different diseases. So in conclusion, key takeaways: genetic medicine is rapidly evolving. It's a promising field. We distinguish between somatic mutations, the ones that you stole grandma's recipe and it does not pass down, versus germline mutation. It's actually the recipe that's mutated that does pass down through generations. We talked about only 5% of patients with growth hormone excess will have an inheritable genetic cause, but it's still important that we pay attention to it because we can do early detection of syndromes, early detection of complications that we are expecting based on the genetics, and we can tailor personalized precision medical therapy. And then we can screen family members. I hope those 2 cases were very representative of how we can change the path of different individuals in your family. So early diagnosis and surveillance, we improve outcome, and we improve prognosis of the disease. So my final thought: integrating genetics into clinical practice enhances precision medicine and elevates patient care. So I'm excited, and thank you for laughing with me and going on this journey with me with the presentation. That's all. Any questions? Yes. Now can I walk or I'm still confined? Oh, yes, okay.
Hi, I'm Marie-Ève Domingue. I'm an endocrinologist. I work in Quebec City. Very nice presentation. Thank you so much. I loved your analogy from the muffins to the grandparents in Florida. I'm gonna steal it from you. So.
I'm honored. Go ahead.
In Quebec, we also have a lot of waiting to see the genetics. So most of the time for the mutations that I am the most comfortable with, as I would be for pituitary disease, I start the counseling myself and I order the test myself. And when it's positive, then I have a quicker access to the genetic counseling. But I cannot do it for everything in endocrinology, but I try to go one step ahead. So it's very difficult, and I would like to have your protocols to see which genes you are testing, and are you doing all the batch all together, or you're doing?
No, we do, so we do pre-test likelihood probabilities first based on everything.
Yep.
With our algorithm, and then we select
specific genes, so you're not doing like a panel.
We're not. Well, we are doing paneling, but not like I said here, right?
Yep.
We've separated them into the most likely as well.
The most likely genes in the first place. Yeah. And are you able to do it in Ontario, or do you? Oh wow.
Yeah, so we have some. So most are going to, for example, Toronto.
Yeah.
We have some Hamilton. We just started the Sioux Area Hospital as well now to have a genetics lab to be able to do certain ones as well. So we're pushing it, but you're absolutely right. Sorry, you're absolutely right. I saw the way. I'm sorry. I told you I was going to move. So the frustration of the 2-3 year wait is something that we deal with all the time. That's actually why we've developed this in Northern Ontario, to try to push it. And I love that you're doing that. I used to do that as well. Get it started. And as long as your patient knows, there's more counseling, right? And as long as those major steps that I talked about, they are aware of it, I think it's safe too.
Yes.
But I think just ordering the test would be wrong. But I like that you're, I've seen it happen, right? Where they just order the test, it's genetics, we'll see, but the patients weren't aware of the risk of the next generation, the risk of telling the rest of their family, et cetera.
Totally. And it's difficult to follow because every time you find one patient that has a genetic mutation, you have to review the literature because a few more genes are available now. So it's you're never there. So
that's why
thank you very much.
Oh, absolutely. And that's why, right? These talks are very informative, but very dangerous, right? So there's always something evolving. I'm sure as we speak right now, we've discovered 2 other genes, right? So, but that's why you need a designated clinic. Yeah, absolutely. Yes.
Thank you very much.
Yeah, absolutely.
I apologize for being late. I just came back from another meeting, so forgive me, everyone. I hope everybody's enjoying themselves. I just heard the part about specifically the genetics, and I have a question and a comment.
Yep.
For the longest time, and I was partly responsible for that, so I'm guilty, we used to say that people with acromegaly have an increased incidence, potentially, of developing certain tumors, both benign and cancerous. And we've always sort of thought that this was an endocrine signal, that growth hormone and IGF-1 were potentially responsible for that. Then we went into the phase where we went to genetics of people getting predisposed to develop so-called pituitary adenomas. And we got into the familial, and I'm sure you went through that part. But my question now is, if you start to select genetic testing in someone who's had acromegaly and a tumor, not necessarily in that order, but let's say acromegaly and then breast cancer, and then you start to select those individuals, or a man with acromegaly and prostate cancer, and you start to look at the whole genome of those individuals, what do you start pulling out?
Yeah.
And I'm asking this as a question because as we do more and more of genetic testing, and as you know, patients who undergo testing because they've developed breast cancer, we're beginning to find out that there are some common elements here. So what are your thoughts?
Yeah, so my thought is, again, I love the fact that we can have a clinic that follows these patients, and then we can extract the data and have a look. It's what our question is, right? So are we looking for associations? If we're looking for associations, that's one kind of project for education. But I think the thought is, can we go into prescriptive genomics? Is our focus, can we change that DNA? If we see a common DNA, that's the future of looking at these associations. That's my hope, right? So that would be my comment. I hope I'm answering your question. It would be, we find the associations, we find what's common in the breast cancer and the pituitary, and see if it is across multiple individuals. Do we have the strength to say that, yes, these are both caused by this one genetic mutation? And if so, push it further and do then look at prescriptive genomics. Is there anything we can do for treatment? Because at the end of the day, if we don't have treatment, what are we doing?
Well,
No.
I think it's not so much at treatment, but it's also to guide something.
Yep.
It's like, so for
Response
example,
to treatment.
you know, how often does every woman with acromegaly
Yep.
have to undergo
Yep.
mammography?
Yep.
And is it going to be different?
Absolutely
at
right.
different ages, and you
Yep.
know, so it's guiding. And I guess part of my questions is perhaps a plea that we need to keep an open mind and appreciating that there's a new power to genetics in cancer in general, and we're doing that anyways. So if we can bring acromegaly into that equation, then I think there can be a lot more of that data to be extracted, you know, to everybody's benefit.
Yeah, and we're hoping our center is going to pump out that data, that research, right, to see if we can find these associations. And I presented 2 patient cases where, because of the genetic testing, we did screening, we did monitoring, we were able to prevent certain conditions. So you're absolutely right. The algorithm will help us predict as well and do our preventative measures. It turns into true preventative medicine. You're absolutely right. Yeah, I love it. Yeah,
so I just want to let you know, everybody knows me. So when I met Dr. Azzola at the Pituitary Society, my brain just went, and I've already got scenarios laid out. So Acromegaly Canada is going to hook up Dr. Azzola, and we're going to start getting out there, making sure all the provinces are doing testing, and they can have the results in their own provinces, but I want to get it to the point where all results go to Dr. Azzola in Ontario so we can get the accurate. So if we're getting testing
she doesn't
done
want me to sleep.
Yeah, if we get testing done in BC for genetics, yes, send it to our endo, but I want that endocrinologist to send it to Dr. Azzola and get all the provinces in line to get the final results for all of Canada. So this is a journey I'll be starting on. I want to start it in January, February, right? So we're going to be putting some information on the website too, like
Absolutely.
just ask your endo if you should have it tested. First step, right? And
I think though too, we need the tool to make sure we are careful about it, right? I think
oh,
the
absolutely.
protocol there too.
Mm-hmm.
So we'll discuss. I mean,
Yeah.
This is exciting.
Yeah.
I was sitting beside her and I was asking too many questions and talking too much. That's how we met. So.
So I think somebody else has a question.
Yeah. Hello.
I think genetic testing is very important, but we can't.
No,
That's really
but
important.
that's why I have to be
Pre-test
careful.
probability is that what we do also, unlike pheochromocyte ganglioma.
Yeah.
But
Yeah.
common.
Yeah.
For germline at least, plus or minus somatic in those. We often use the genetic team at our site. I know the wait lists are long, but once you get to know some of them,
We don't have
a little
one.
bit of a pull, right?
Yeah.
Get to know the names and friends. Sometimes the paperwork for non-Ontario based, they can really help out with the MOH paperwork, which takes a lot of time.
Yeah.
Time consuming, so I find them very valuable. Those kind of things. Are there rare endocrine? There is still a value in getting them involved early for those kind of things, especially for other rare conditions. Well, where it's easy for us to order MEN1 and other panels.
Yeah.
So very valuable early on. Yeah. But the waiting lists are.
And that's why I wanted to be careful, right? I'm not saying every acromegalic patient should be genetically screened. There's only 5% that have a genetic mutation, but it's important to catch that 5%. So that's where the algorithms, your pre-test likelihoods are so important as well. And I completely agree. I'm working on trying to get that kind of center. Right now, we're trying to grow it so that we can have them part of our team. That doesn't exist right now in Northern Ontario. Yeah. So,
Don't give up.
And I never do. I'm stubborn. And your wait list is probably so long because we're going to you, right? So hopefully that'll relieve some of it. Yeah. So hopefully we'll relieve that. Our turnaround we'll help each other. Yeah, it's teamwork. Anyways, but yeah. Any other question? One more question, okay? Yes?
Yeah, great presentation, Doc.
Thank
Thanks
you.
a lot. I wonder if you could clarify the FIPA, or the familial isolated pituitary adenoma. Is that 5% of the population or the AIP?
No, so
The FIPA is mostly everybody.
So so when I say 5% of the acromegalic tumors are genetic, I'm talking about all genetic mutations. So including somatic, including germline, including syndromes. I'm lumping them all in together as 5%. And then we can break them up afterwards, but it's for all of them. Yeah.
Do you have a thought of most acromegaly patients belong to the FIPA?
Oh, it's a very common one.
Yes.
Yes, it is one of the most common. Absolutely. Yes. Oh, you're absolutely correct. Yeah. Mm-hmm. Yeah, no problem. Well, thank you. This was fun. You guys were a great audience. I had a lot of fun, lots of giggles, and I hope lots of learning for you guys. And just thank you so much.